Well, I think it's just about time. So I'll maybe go ahead and get started. I'll start slowly, see if any more people join us. But thank you for tuning in. It's good to see you all. I chose this article mainly because I like the topic. And because I really just wanted to learn more about what the crit line can tell us. I feel like we use it so frequently during our extracorporeal treatments. And I was just interested, as always, how this compares with human medicine. And how, that can inform what we do, although these patients are a little bit different to our own population. And I chose this particular article because there's a lot out there on intradialytic central venous oxygen saturation, but I like the way it combined that with changes in relative blood volume. And so I was planning to start with a little bit of background first and then move on to the article itself, but please feel free to interrupt me at any point. I'm interested in any thoughts, perspectives, or experiences anyone else might have. And one thing I found, when I started reading around this topic, there's this great human review article out there, which compares the physiologic adaptations that are made by Sherpas in order to live and to thrive in a relatively hypoxic environment because they live at such high altitude. And they compare it with all the maladaptive processes that happen in hemodialysis patients who are also subjected to regular periods of hypoxia themselves. And so the very thing that's life-saving about hemodialysis can also cause some physiologic stress on the body because of these rapid changes in blood volume, electrolytes, acid-base status. And a lot of the tissues in the body have to increase their metabolic activity, and they have an increased demand for oxygen in the face of relatively reduced oxygen availability. And some of that's going to depend on the modality, the length of treatments, and also, of course, ultrafiltration rates and volumes, and any periods of intradialytic hypotension. And so one of the main focuses for a lot of the articles I found about dialysis-induced stress is on the heart. And certainly it's widely reported there's a very, very high rate of cardiovascular morbidity and mortality in hemodialysis patients. And although in people there's lots and lots of traditional risk factors, I think one of the premises for this paper I'm going to discuss today is the fact that above and beyond that, there are thought to be some cardiovascular consequences from the hemodialysis treatment. So if there's any periods of relative hypoxia for the heart, that can cause some regional segmental systolic dysfunction, so myocardial stunning. And over time, if there's repeated episodes, that can lead to permanent dysfunction. And ultimately, those areas will scar, the heart will start to remodel and ultimately might fail, and the patient may die. And not only is this going on in the heart, but potentially in lots of other organs as well. And of course, usually we know that the oxygen supply in most normal patients is usually far in excess of what's actually needed by the body until we get to a critical level. And then after that, any further decrease in oxygen delivery will lead to tissue hypoxia. And that critical oxygen delivery level will vary a little bit dependent on the species, disease states, and also some of the physiology of the individual patient. And so most of that oxygen, as we know, is needed by mitochondria for aerobic respiration. And they can do pretty well until we get to an environment with a partial pressure of oxygen of around 1 millimeter of mercury, which is pretty amazing. But a lot of the time in most hemodialysis treatments, oxygen delivery will decline to some degree. Many reasons, so some of it being the reduced preload because we're ultrafiltering, we're pulling off a volume of blood at the start of the treatment, myocardial stunning that we talked about, potentially arrhythmias, even if they're intermittent, And certainly, again, as we mentioned before, that repeated or persistent subclinical hypoxia can initially be reversible, but ultimately may start to lead to cell death and organ dysfunction. And I guess other critical is certainly we learn about all these ways of measuring tissue oxygenation and extraction, and all of these equations that we look at. And if you have access to some mixed venous blood, and you can measure cardiac output, we can do lots and lots of fancy calculations. I certainly cannot remember all of these off by heart nowadays, that's for sure. But the problem being we need a pulmonary artery catheter. And so alongside all of the complications that can entail, even if we can use it safely, in most patient populations, it's probably not actually going to translate to improved outcomes or reduced mortality. And so really that's when we start to focus on central venous oxygen saturation. So again, this was good for me to have a little read about and remember. So now instead of pulling blood from the pulmonary artery, we can take it from cranial vena cava or right atrium. And certainly we know that this information can be very useful. So we know that extremes, either low central venous oxygen saturation or if it's particularly high, and both of those extremes have been associated with mortality in the critically ill. And certainly we have some information in dogs as well. So this was an experimental study that I found, and they correlated central venous oxygen saturation with mixed venous oxygen saturation. And these poor dogs were subjected to hemorrhage, resuscitation, various hypoxic, hyperoxic conditions. And these seem to trend pretty well throughout. And we know that based on the blood that we're collecting, we're going to see some difference between these measurements. And in most circumstances, central venous oxygen saturation will be a little bit less than mixed venous oxygen saturation. So a lot of that to do with the brain taking up a lot of oxygen. And then in the caudal half of the body, or bottom half if you're a person, blood flow like through the kidneys, we know they see an awful lot of cardiac output, and a lot of that they're not actually extracting oxygen, so that really explains it. But then we get some differences depending on where we put the catheter tip. So it could be it's just about intracranial cava, or it could be you have a hemodialysis catheter that's actually well seated in the right atrium, and so again those levels are going to vary a little bit. And then certainly in shock or anything, brain injury or anesthesia, we could see that relationship reverse and things become a little bit less predictable. So during shock, that splanchnic and renal circulation will see much less flow, and circulation gets redistributed to the upper or cranial half of the body. In TBI or anesthesia, decrease in cerebral metabolism may decrease oxygen extraction by the brain. And in those circumstances, that situation can switch, and we see central venous oxygen saturation can be anywhere up to 20% higher than mixed venous oxygen saturation. And then this was a really nice review article that I was reading through that I think showed all the components that we're looking at when we're reading central venous oxygen saturation from the crit line. So anything from hemoglobin levels to cardiac output to extraction by the tissues, the microcirculation, how well mitochondria are functioning, and arterial oxygen levels as well. So all playing into that reading that we get. And so looking at clinical use of central venous oxygen saturation outside of hemodialysis, certainly a lot of research on utilization in people. So anything from responses to fluid challenges, guiding transfusions in trauma, predicting return of spontaneous circulation during CPR, and many, many more articles out there. And in dogs, we certainly have some evidence that this paper was published, I think in 2011, this one, and this linked an initially low central venous oxygen saturation with increased mortality. And a little bit like lactate and lactate clearance, not just that a low initial level is bad, but if you fail to normalize during resuscitation, that's also associated with increased mortality. And then getting back to the population that we're really interested in, hemodialysis patients, all the reasons they become hypoxic. And I think one interesting thing that I found in a lot of human articles is that there seems to be this bimodal pattern of hypoxemia. And certainly I think we've all heard about at the very start of treatment that when blood hits the membranes and the materials in the extracorporeal circuits, that we potentially see this complement activation and leukocytes that crowd into the pulmonary capillaries. And although materials now are much more biocompatible, that has been proposed to maybe explain some of this initial drop. And then what we may see over time as we ultrafilter these patients, we pull off some fluid, assuming they're fluid overloaded, we might actually see some improvement in cardiac output and in oxygen getting distributed to the tissues. Plus we see some increasing hemoglobin levels. So that may improve things. And then ultimately, as we pull off more fluid, potentially we're going to see preload decreasing and we get decreased tissue perfusion and a second decline. But many other theories as well. So anything from failure of autoregulation, mechanical stress causing red blood cell damage and changes in oxygen carrying capacity, certainly the effects of fluid overload. In people, they seem to become more hypoxic if they sleep during their treatments because of a high rate of sleep apnea. I don't know that this necessarily translates to our patients. I mean, maybe if we had a brachycephalic who was sleeping and had some sleep apnea or soft palate getting in the way as it does. So potentially some relevant points here, but I think some of this more particular to people. And then just some other things that I was reading about as I read around this topic. I guess I hadn't really thought about the effects of if you give a lot of bicarbonate or if you change pH very quickly, perhaps you decrease ventilatory drive, or if you're left shifting the oxyhemoglobin curve because of the increase in pH, that maybe there's less offloading of oxygen in the tissues, so that might cause a relative hypoxia for tissue beds, and also just the changes in electrolytes it might cause, so changes in potassium and ionized calcium that may affect cardiovascular function and blood pressure as well. Some microcirculatory dysfunction. So I think a lot of this is happening at a microcirculatory level. So it may not be things that we can pick up with our usual cardiovascular parameters, but certainly it seems that any critically ill patient or anyone with kidney disease can develop a decrease in capillary density and less perfusion of their capillaries. And that's going to be even more exacerbated by any tissue edema in a fluid overloaded patient, if they're anemic and hemodiluted, and certainly platelet activation and microthrombi that might form, which we might expect more in our patients with chronic kidney disease, but also could see in AKI. And this was an interesting study. This was an experimental study where some rats underwent hemodialysis, and they looked at what happened to the microvasculature. So these weren't azotemic or uremic at all, but just the process of performing hemodialysis on them. These red rectangles show how microvascular perfusion decreased even 1 or 2 hours into treatment. And then finally, mitochondrial dysfunction in kidney disease as well. During kidney disease, so again, whether that be AKI or CKD, certainly they seem to develop a decrease in mitochondrial density. I think some of this is a protective mechanism, oxidative stress, and there's uncoupling of oxidative phosphorylation. If mitochondrial fragments are released as they're destroyed, and that can act as damps and just really perpetuates this inflammation that we see. And so it's really adding to this whole inflammatory soup. And so not only is it a consequence of kidney disease, it could contribute to progression as well. And so in terms of systemic consequences of these hypoxic episodes in hemodialysis patients, we learned a little bit about hypoxia-inducible factor, and maybe that's a therapeutic target under some circumstances. But as that's released, particularly in the pulmonary circulation, could perpetuate pulmonary hypertension and hypoxemia. Of course, hypoxia is pro-inflammatory. It's thought to be catabolic as well, so it may contribute to some of the cachexia and muscle weakness and frailty seen in at least people with who are undergoing hemodialysis chronically. Hypertension, so we know there's a massive sympathetic response to hypoxia, so that could contribute, as well as end organ damage. And the role of oxygen therapy in all of this, I mean, you imagine it's probably not going to hurt to supplement oxygen, but does that really translate to improvements in oxygen supply to the tissues? So let's get on to the actual article. And so I found this, this was published in 2023, and it's in Hemodialysis International. Just worth mentioning some conflicts of interest. So 4 of these lead authors, and Peter Kotanko seems to be quite widely published on this topic. I find his name crops up a lot when I was reading around this topic, but they are employed by the Renal Research Institute, and that belongs to Fresenius. So they carry out a lot of research, clues in the name, but they also have clinics as well. So they also have patients, and they carry out hemodialysis for many patients as well with kidney disease. The lead author, he does hold stock in Fresenius, and this whole study was funded by Fresenius. So I think worth bearing in mind, I mean, this is not a new product that they're trying to bring to market. I think people are very aware of the crit line. We all know that it's very, very useful, but I think they certainly won't want it to look bad. So I think just something to bear in mind. In terms of the introduction, I think they had a lot of references, actually. There was like 18 references in this introduction. And they really led with what we started all of this with, that the real reason for performing more research in this area is just the very, very high rate of cardiovascular disease and certainly mortality in maintenance hemodialysis patients. And although people have lots and lots of risk factors, but really don't bear much relation to our small animal patients, there also seem to be a lot of non-traditional risk factors. And much as, you know, what we've been discussing in the first part of all of this. So they had some good references. My favorite was this recurrent circulatory stress, the dark side of dialysis. It was very dramatic. And this is actually an editorial, but it was really good. So that was definitely some good references I found in here. I guess the only thing with the central venous oxygen saturation, they had a couple of references, and they're saying it's frequently used in non-dialysis populations as a hemodynamic marker. And their references were a little bit older, and one of them is this Rivers study from 2001, and then this 2004 article as well. I felt like maybe there was probably some more recent references out of there. And then just as a reminder, with the Rivers study, which was really a landmark trial and changed the face of human critical care for a while, this was where they had a strict protocol-driven approach to shock resuscitation in people with severe sepsis or septic shock. And a lot of these endpoints were included, but one of those was to aim for a central venous oxygen saturation of at least 70%. And they found a pretty startling reduction in mortality in these patients, so 16%. So this kind of took the critical care world by storm, and it was incorporated in the surviving sepsis guidelines. And there's been many trials more recently that have been run along similar lines and question the results. And there's certainly been not necessarily some criticisms of the paper, but just the population they studied is maybe just not as representative. And this may just be that times have moved on a little bit and ICU care has changed. And things like lactate clearance are now really just shown to be non-inferior. But a lot of these patients will have a central venous catheter anyway. And this is just a little selection of the references that were found in this introduction. And as they point out, if we do have a hemodialysis patient who's already got a central venous catheter, it's very, very easy for us to measure these things and for us to use the crit line. And then what we do know about the topic is that a large majority of hemodialysis patients, chronic hemodialysis patients, will develop a central venous oxygen saturation under 60% at some point during hemodialysis. Just those low levels, as well as repeated episodes of decreased central venous oxygen saturation, as well as high variability, all of those things have been associated in previous studies with increased mortality. And that hypoxia can go on even past the end of the treatment. You'd think that it would quickly improve, but that's been shown that it can actually persist for up to 4 hours post-treatment. And then the other thing that's a little bit scary is you might not actually see any change in how the patient feels. Of course, it's very, very, difficult for us to know that with our patients, but changes in heart rate or blood pressure are not necessarily seen. Just some of my thoughts on the introduction. I do think it's well referenced. It's pretty succinct, I think very appropriate for this target audience. I really like it. Was just a few paragraphs. I think they said what they need to say. This is an audience that does perform hemodialysis, so they can assume knowledge of a lot of this. And I think they have a very clear knowledge gap and justification for the study as well. So they kind of present this paradox that on the one hand, a low central venous oxygen saturation, which has been associated with high ultrafiltration volumes and rates, is bad. So it's associated with increased mortality. But if you don't have a rapid decline in your blood volume and you're not tolerating high ultrafiltration volumes and rates, then that's also bad. So it's this kind of paradox. And so the aims of the study were to explore the joint association between central venous oxygen saturation and relative blood volume changes, and those parameters together, how they influence all-cause mortality in this population of chronic hemodialysis patients. They also wanted to look at how fluid removal factors into that, and also ultrafiltration rate as well. And so in terms of study design, this was a retrospective study. It was a cohort study. They followed a group of patients over time, and it was in 17 of these Renal Research Institute clinics across the US. And their population, they were all maintenance hemodialysis patients. I'm not totally clear if there was a minimum amount of time they needed to have been on dialysis. I mean, presumably between when they started collecting data and that 6-month baseline period for sure. But this diagram shows how they collected them all. They collected data over a 6-month period, and then they followed them up for 3 years. And then one thing that did strike me was that this data is a little bit old. So this was all done between 2012 and 2015. And this paper was published in 2023. And it just got me thinking, I wonder if they've used all this data before for other studies. And I think that's what they actually did, because this diagram I got from another paper by the same authors. So I think they're just going back and using the same data set and coming out with new papers, which is totally fine. But I think, you know, it's a slightly historic population. You know, we're getting on for 10 years ago now. So I just wonder if things have changed very much in that time. In terms of inclusion criteria, the patients all had to have had at least 10 hemodialysis treatments during this baseline period. They all had to have central venous catheters. And so this was one reason that I picked this as well, because I think this was maybe a little more applicable to our patients, where we perform our extracorporeal treatments always with a central venous catheter. And they had to have had crit line recordings as well. And there were a lot of comorbidities, I guess is to be expected in a chronic hemodialysis population, but they included patients with diabetes. Some of them had congestive heart failure, they had COPD, and those were the most prevalent comorbidities that were included. For exclusion criteria, anyone who had central venous oxygen saturation readings of over 80% were excluded, because they thought that was probably misdocumented, if that's a word, but they thought it was unlikely to be central venous blood, so they excluded those. They also excluded anyone with levels less than 25%. Being incompatible with life and probably more likely due to a loose connection, hopefully not in the bloodline. And then anyone with a relative blood volume greater than 102%, I guess that's also unphysiologic. And then also people older than 90 years. And initially, I thought maybe that's due to that age being a confounder. But actually, looking into this a bit more, it seems to be part of the regulations when you take a patient data set and you identify them. And I don't know if it's because there's so few patients maybe over 90 years, but it's just really hard to keep them anonymous. But they had to do that. That was a requirement for data regulation reasons. And then we're all familiar with the crit line monitor. So we know that the blood chamber fits into the extracorporeal circuit, and there's a sensor clip that fits over it. It's a little bit like a pulse oximeter. It will emit multiple wavelengths of light, and then it will measure the differences in light absorption, and it can, from that, tell you how much of that is hemoglobin, so we can get an idea of hematocrit, and also it can measure how much of that hemoglobin is carrying oxygen, how much oxyhemoglobin we have. It's pretty amazing. I didn't know this. It will take its readings of the hematocrit and oxygen saturation of the blood like 9,000 times a minute, but it takes an average of all of those readings and it will report it once per minute. And then of course it calculates blood volume change based on changes in hematocrit. And so they do report at one stage, but the accuracy of the crit line is 2%. And I'm not totally sure where that comes from. I went into the specs of the crit line and I found these ranges. And there is a dog paper a canine paper along the same lines as this, which I will mention later on. But certainly the accuracy of the readings can vary a little bit. I think plus minus 3 to 5%, it's probably not going to hugely change what we do clinically. But just to bear in mind, it can be affected by changes in hematocrit, especially if they're very low. I don't know amongst these patients if there were any that were anemic. They do report at some stage, but the hemoglobin, it seems to be 10, so I assume their hematocrit's 30-ish, and they all seem to be of a similar level, but it's hard to know. But just to remember, if a patient's very anemic, that it might affect the accuracy, just as it would with a pulse ox. And also things like big changes in sodium might affect it to some degree as well. So that was just good information, I think, for me to read through and learn about. And then they divided all of these patients up into 4 groups. And this took me a little while to get my head around. So groups 1 and 2 had the above average central venous oxygen saturation. And then groups 3 and 4, they were below the median. But the relative blood volume change they then used to subdivide those groups. And I ended up being very visual. I really like a picture for everything. So I ended up making a little picture just to get my brain around this, because groups 1 and 3 are subdivided into relative blood volume less than the median. And by this, they mean that they lose more than minus 5.5% or 6.5 mil per kilo per hour. So those are actually the ones where more fluid can be pulled off. And then groups 2 and 4 are above the median. So they mean that those are not tolerant of fluid being removed. So they have less change in their relative blood volume and less total fluid volume pulled off or ultrafiltration rate. In terms of stats, their main primary objective is survival times. So they use Cox proportional hazard models and Kaplan-Meier curves. They do some adjustments for age, diabetes, and dialysis vintage. They look at the association between central venous oxygen saturation and change in relative blood volume with mortality. And they present some of this data as contour plots, which I don't think I've encountered them before, but I think they're actually really nice. So I've got a couple of those in some upcoming slides. In terms of results, these pictures are not from this actual paper, but they got 216 patients with just over 5,000 treatments overall. I was a little bit confused, and please, someone, if I'm being silly, tell me, like I might be missing this, but the dialysis vintage was reported with a mean of 2.7 years and a standard deviation of 4.5 years. And I guess I just wondered, like, how can you have that if it's normally distributed? So either, I guess the data is very skewed, or I don't understand how that could be normally distributed. But again, please interrupt if I'm just missing something really obvious, then totally tell me. But the average of their central venous oxygen saturations they found amongst their patients was 58.9%, and overall they decreased by nearly 3% during the treatment. The overall mean relative blood volume change was 5.7% decrease, and their mean ultrafiltration rates that they were able to achieve throughout this population was 7.1 mil per kilo per hour. They report an overall mortality rate of 20%, and that's where these pictures come in. I guess I didn't have a sense of what they were expecting and what's normal. I guess if you read Hemodialysis International, you probably know this, but I just wanted to get a sense of how that compares. And so I ended up finding this article, and it was an epidemiological study of all global hemodialysis outcomes. And they found in the first 3 years of treatment that mortality would be anywhere between 17 to 27%. And so I think that probably tallies fairly well. And they did raise an interesting point that actually a patient who has a central venous catheter and is being dialyzed through that might already be being selected for higher mortality. So they're patients who maybe they're sicker or just less tolerant of more permanent options. Maybe they're awaiting, I don't know, transplant or something of that kind. So I did think that was interesting, the fact that these are all central venous catheter patients. And does that mean anything in terms of their mortality rate? Some factors that influenced mortality and was statistically significant, certainly age, the longer they were being dialyzed, if they were diabetic, if they developed more fluid overload and it was not possible to pull off that fluid during treatments, lower blood pressures, lower serum albumin, higher ferritin, and a higher neutrophil to lymphocyte ratio. I did notice some of these things, although they're statistically significant and it makes total sense, looking at the differences in albumin between the survivors and non-survivors, for example, I did just wonder how much you would appreciate that clinically. So if you have an albumin of 3.8 grams per deciliter, you're going to do okay versus 3.6, you're more likely to die. And of course, this is population-based. It's not something we plan to apply to our individual patients. But they never really commented on the clinical significance of these points. And it's really something for the discussion, but I did think that was just something that struck me just looking at some of these numbers in a bit more detail. In terms of mortality, as we might expect, if you have a lower mean central venous oxygen saturation throughout your treatments, you're more likely to die. And that difference is 55.6% on average versus 58.9%. If you have a greater decline during the treatment, again, more likely to die with a 1% difference. And if you have a lower relative blood volume change, then that means you're also likely to have a higher mortality. And again, that was 5.3 versus 5.8% decrease. And in terms of survival, the patients who had the greater change in relative blood volume tended to do better and had the higher survival, but the higher central venous oxygen saturation was more important. So groups 1 and 2, who both had the higher central venous oxygen saturations above the average, despite their relative blood volume change, they both had an increased survival. And this is one of the Kaplan-Meier curves. So this is looking at combined central venous oxygen saturation and relative blood volume change on mortality. And so we can see group 1, who has a higher central venous oxygen saturation and a greater relative blood volume change, definitely does better than the others. This is one of the contour plots that I mentioned, and I think it's really nice. This may not work as well if it's not in color, but they're plotting the average central venous oxygen saturation on the y-axis, and then the change in relative blood volume on the x-axis, and then they're dividing up the quadrants to represent the different groups. And reading this like you would a map of a hilly area, and the actual altitude is the hazard ratios they got from their Cox models. And so you can see, if we're using group 1 as the reference, just how much better visually groups 1 and 2 are doing than compared to 3 and 4, because of their higher central venous oxygen saturation. This is the combination of central venous oxygen saturation with ultrafiltration rate that was achieved and that association with mortality. And it's slightly different here, but ultimately the group with the highest central venous oxygen saturation and the highest ultrafiltration rates did better and worst off. So group 4 had the lowest central venous oxygen saturation and the higher ultrafiltration rate. So that was above median. So that kind of mixed things up a little bit. But when they did adjustments for age, diabetes, and hemodialysis vintage, a lot of this lost clinical significance. So I think you have to really tease through these results to work out what was significant in the unadjusted analysis and what retained significance after. I had to read this through a few times to really, appreciate that. And then finally, in terms of the discussion, we're getting through this quite quickly, aren't we? The larger relative blood volume decline and the highest central venous oxygen saturation levels were the most associated with improved survival. And they had a couple of theories. I guess if you're able to pull off more fluid and retain higher oxygen levels, venous oxygen levels, and probably that implies you've got a higher cardiovascular reserve, you're more tolerant. And I think what's difficult to tease out from here is whether you're going to do better anyway. The fact that you are able to tolerate all of this fluid being pulled off means that you're already doing better and you're more likely to survive. Or is it the fact that you take off all of this fluid, you decrease and address all of the fluid overload, and actually by doing that, you're improving their mortality? And so when they say in patients with higher intradialytic central venous oxygen saturation, high ultrafiltration rate may be better tolerated and fluid overload can be easier prevented, I think it kind of, as I say, I don't know that. Is it that they're going to do better anyway, or is it what you're doing is making them better, or is it a little bit of both? They did add in this paragraph here that I've just included at the bottom. This is one of the paragraphs in the discussion. They start talking about whether central venous oxygen saturation can be used as a surrogate for cardiac output. And they mention this study that was looking at basically measuring thoracic impedance. And they found that hypotension-prone patients had a more significant decline in central venous oxygen saturation throughout their treatment. But they don't really make any comments on it. And I'm just not really sure what relevance it has to this discussion. It's almost like they left it in by accident. But I did think that was a little bit random in the discussion. They then go on to talk about, sorry, this is not a very pretty slide, it's very wordy, but they go on to talk about the fact that if you don't tolerate a relative blood volume decline greater than 8% in 3 hours, that you are more likely to have increased mortality. And they go on to discuss this paper that we're reviewing, and they say it not only corroborates these earlier findings, but also adds to their interpretation by showing that low central venous oxygen saturation levels augments the mortality risk associated with small relative blood volume changes. And they also make some comments about, changes they found in unadjusted analysis, which were then lost and didn't reach statistical significance in the adjusted analysis. And I don't know, I was really having to read through. I think it's really hard from this data set to prove that the fact that you are removing more fluid and therefore that causes this change. And I just don't know if some of this was a little bit overstated, and the fact that some of this following adjustment wasn't statistically significant. So I do think there's a lot of discussion about a lot of these things, and undoubtedly they found a relationship. And I think these are all like really good theories on why that might be the case, but I don't know if this study can necessarily prove a cause and effect. And they do go on to say in their limitations, it's a retrospective study, and they can't prove causality. So they do very explicitly state that. I think some things I was thinking about, these are all patients who have congestive heart failure, they have COPD. It would have been really nice to have some measure of cardiac or respiratory function. We know those things are important and would likely influence central venous oxygen saturation. So it would have been nice to measure those, but they don't seem to be a critically ill population. I don't know if these clinics are all outpatient clinics, whether they do have any sick patients who are septic, post-surgery or trauma. I'm guessing they're an outpatient population, and so that's probably less of an issue, but it would have been interesting to know. But of course, there's no way they're using a data set that's retrospective. It's from 10 years ago. There's no way they can do all of that. You would need prospective studies. And I did wonder, did any of these patients, I mean, presumably they're all undergoing intermittent hemodialysis, but did they have any that recovered or dropped out, or went to another facility that were lost to follow up? Maybe they just excluded all of those and they just weren't in the data set to start with. And then they talk about a strength being standardized care protocols. And I can imagine, you know, these are all clinics run by the same people. They probably have the same sorts of protocols. So I can imagine compared to 17 completely different hospitals, they probably do have much more standardized protocols. Oops, oh my, what have I done? Hang on, let me just go back. Previous. Okay, so in conclusion, intradialytic central venous oxygen saturation is an important effect modifier that should be considered when interpreting the association between relative blood volume change, ultrafiltration rates, and outcomes. And mortality risk is particularly increased with patients with concurrent low central venous oxygen saturation and small relative blood volume changes. And so it just got me thinking, can we apply any of this to our small animal patients? And certainly, I mean, these are people, they're on chronic hemodialysis, and they have lots of comorbidities and things like coronary artery and vascular disease, but our patients just simply don't have. So I think, of course, it's a completely different population. But if we were to take anything from this, and I think some of my thoughts, I'll be interested to know what anyone else thinks, but some of my thoughts on what we might be able to take from this next time we have the crit line on one of our patients during an extracorporeal treatment. I think certainly one thing is, how well does the crit line measure oxygen saturation in our patients? And I found this study, and there's actually a few studies out there, and they compare the hemoglobin wavelength absorbance spectra between people, dogs, and cats. And they found actually, and these graphs represent that, but actually they're fairly similar. And so the wavelengths that represent oxyhemoglobin versus deoxyhemoglobin, actually that's why pulse oxes and probably this technology, when they're measuring saturation directly, can be pretty good. And so we can probably translate that fairly well. And we just have to be a little bit careful if we're putting blood using a co-oximeter that's going to calculate saturation for us, and from a partial pressure of oxygen, we have to be a little bit careful if those machines are using human algorithms. But of course, that's not what the crit line does. I do think one thing is that probably our central venous oxygen saturation readings could vary quite a lot with the catheter tip position. So that could mean, I mean, honestly, in a lot of our hemodialysis catheters, we do have them in the right atrium. But if they're going into the caudal cava, that could well actually cause your patient to have a different range of normal. And certainly short catheters that are more in the cranial cava, again, are probably going to be very different in terms of their readings as well. Another thing being that high central venous oxygen saturation is not necessarily a good thing. So the higher the better in this paper, but ultimately, if we are dealing with sicker patients, maybe septic patients, actually, if we have a high reading or it's a very high reading, it might raise concern of these tissues just not able to extract oxygen as well. Do we have capillary shunting or changes in the microvasculature so we can't get oxygen to the tissues? Or do we have a very left shifted curve, for example, and a change in hemoglobin affinity for oxygen, so it's not actually able to offload oxygen to the tissues as well? And then another thing, I just found another paper looking at the crit line in dogs undergoing hemodialysis. So this study here, and they looked at the accuracy of crit line readings in predicting hematocrit and change in blood volume. And they found the crit line 4 performed better than the 3, so it was more accurate. They found that, again, as we mentioned earlier, that changes in PCV or hematocrit could change the accuracy of the crit line. So when the PCV got over 25% for the crit line 3 or over 30% for the crit line 4, they found the readings were slightly less reliable, but I guess we can always check a PCV manually if we want to. And certainly it didn't seem that the readings were likely to be clinically that clinically significant. And also the blood volume change becomes less reliable when you've had a change of greater than 20%. That's probably going to be a relative minority of our patients, depending on what we're doing, but certainly something to bear in mind. And I ended up, this kind of reading about all of this gave me a little bit of a renewed appreciation for all the things that go into that reading that you're seeing on your crit line monitor, and the changes that it could reflect. So anything from cardiac output to hemoglobin levels, but also just things like sedation or analgesia. So maybe those patients, if we've anesthetized them, the AKI patients, and placed catheter and the E-tube for the very first treatment, perhaps when they're recovering from anesthesia, we're going to see different readings to subsequent treatments where they're awake and maybe a bit more restless, or perhaps based on temperature or even microvascular perfusion and what the mitochondria are up to, all of those things that could affect that reading. And then I came up with some future research questions. So I think, sorry, again, this is a horrendously busy slide, but what is the accuracy and precision of the crit line for central venous oxygen saturation? So in dogs and cats would be good to know. Do they develop any form of microcirculatory stress during hemodialysis treatments or other extracorporeal treatments? When we're using these numbers, what would be the optimum readings? What actually translates to better patient outcomes, reduced mortality, maybe quicker recovery potentially, and then all of these other things that I thought that could be good sort of talking points or areas for future research. So that is all I have. I'm happy to answer any questions or like anyone else's perspectives on this. I'd be interested to know. All in stunned silence.
Have you changed anything with how fast or slow you're trying to ultrafiltrate your patients now?
I guess that's something, I'm a little bit of a wimp anyway, potentially. I think I always remember that paper and feeling comfortable up to about sort of 8 to 10 mil per kilo per hour. And I think their average 7 mil per kilo per hour probably tallies in with that. We did have a patient not so long ago, though, that we were just getting huge volumes of fluid off. And I guess I don't know if I've necessarily changed things, but it's making me think about it a little bit more, and maybe paying attention to that central venous oxygen saturation level. And I think if we have a very heavily fluid overloaded patient, I think we'll probably still try and push them a little bit more. But if I did see a dip in that central venous oxygen level and it was a significant change, I think I'd probably be more likely to pay attention to that and think about, right, do I really want to achieve all of this in one treatment, or should we actually be making the treatment a little bit longer? So I think it's difficult to measure all of this, but I think it's made me more aware at least.
I mean, it's definitely interesting. I would say I'm at Friendship right now. I'm always leaned towards being a little bit more aggressive with UR, but maybe pushing it out to a second treatment if it doesn't seem like they're tolerating it. I mean, certainly we have the crit line and everything that we can, but yeah, it was an interesting thoughts today. Thank you.
Oh, of course. And no, that's true. And I wonder if our patients are a little bit different. I mean, the one I'm thinking of was just so horrendously fluid overloaded. I mean, she literally, even at the end of the treatment, when she came off the table, like the fluid you could see, or the edema, it literally molded to the shape of a table. I mean, she was horrendously fluid overloaded, and we pushed her really hard, and she seemed to tolerate it. And I do wonder, it's probably unlikely that in human medicine they see anyone quite that fluid overloaded. So maybe there's a population difference as well. I feel like definitely with those guys, so many consequences are suffering because of that fluid overload. I think it still makes sense to push those ones for sure. And she was particularly fluid overloaded. So
I do feel like we, especially get like our lepto patients that are otherwise so young and healthy,
yes.
and then get massively overloaded, are probably the best ones to tolerate this anyway. So,
oh, totally. Yeah, totally. And I think, again, these people, I mean, the fact that they're doing this in people with congestive heart failure, like they're actually in heart failure, is just, you know, it's just totally different to like you say, those young, otherwise healthy lepto patients, and where we can pull a lot of fluid off, and they're just, it's like you can almost see that instantly, like, oh, everything, you know, they start peeing and everything improves. So I think very, very different beast. And I certainly wouldn't want to advocate for not pulling off fluid when we need to, and not pushing those patients a little bit more, knowing all the benefits we get. But maybe where we have a more borderline patient, and also these are the chronic patients as well. So that's the other thing. So maybe those patients we are seeing 3 times a week now, we're in a routine where maybe it's a little bit less of an acute situation, just maybe the trend over time might be more helpful with those. If we're seeing a very persistent dip or they're not tolerating it well, maybe that's a time to think about a change in our prescription. But yeah. Well, thank you all so much for coming.
All right, thank you so much. And we have another session next week, as well. Is it next week? Let me see. I think it might be on the 30th. So we will see you guys hopefully all then. Thanks so much, Dr. Philip.
Thank you. Thanks for all coming. Appreciate it. Good to see you all. Have a good rest of your day.
Thank you.
Bye. Thank you.